Hello everyone. I am Dr. Keval. I am Associate Professor at the UN Mehta Institute of Cardiology and Research Center, Ahmedabad. I'll be discussing the role of GLP receptor agonists in cardiovascular risk reduction. Now, this is not purely a cardiac molecule. This molecule exerts its effect on blood sugars, inflammation, cardiovascular function, renal function, the stomach, even the neuroendocrine system. So this is actually a CKM type of molecule, a cardio-kidney metabolic molecule, which has multifactorial mechanisms of action. It's the mechanism of action, just like an SGLT2 inhibitor, is not restricted to a single organ or a single mechanism of action, but works by different pathways in different organs of the body. So we'll be discussing it under the following headings: the introduction, the mechanism, the cardiovascular effects, the trials, comparison with SGLT2, and the future direction, and the final conclusion. So introduction, this topic needs no introduction. Diabetes, we know, is a major risk factor for ASCVD. Diabetes is like a prior MI in terms of future event rates. It's a leading cause of morbidity and mortality. We know that there are millions of diabetics in our country as well as worldwide, and diabetes really accelerates the development of cardiovascular disease, also leading to significant increase in the rates of CKD, heart failure, peripheral vascular disease, as well as neuropathy. So obesity, diabetes, overweight, metabolic syndrome all go hand in hand. Diabetes affects almost 50 crore people annually, which is expected to increase much more significantly in the next couple of decades. The burden is going to increase because these diabetic patients have associated dyslipidemia, CKD, albuminuria, and a growing spectrum of cardiometabolic diseases, including inflammation, atherosclerotic cardiovascular disease, strokes, and peripheral vascular disease. The management of diabetes previously used to be sulfonylureas, metformin, then we have had other agents like pioglitazone, then we had TPP4 inhibitors, and then we had SGLT2 inhibitors. But now the future is changing, and in 2008 the FDA mandated that all anti-diabetic drugs needed to have a cardiovascular safety outcome data, and hence since 2008 the drugs which have come in the management of diabetes, particularly the SGLT2 and the GLP-1 receptor analogs, all have proven cardiovascular safety data, and these trials have also significantly changed the management of diabetes and associated atherosclerotic cardiovascular disease. Coming to the guidelines, GLP-1 receptor agonists with proven cardiovascular safety are recommended independent of the glycemic control in patients with diabetes with ASCVD, and they also reduce the major adverse events and reduce the major adverse cardiovascular endpoints, with the observed effects especially strong for reducing the ischemic events in patients with ASCVD. They have positive effects on the weight as well as blood pressure and the blood lipid levels, reduce the inflammation, oxidative stress, and also have additional anti-atherogenic and anti-inflammatory effects. Also, they have positive effect on the renal function, reducing the albuminuria as well as improving the renal functions. The physiology of GLP-1 receptor agonist is one of the first GLP-1 receptor agonists which was found and which was approved was the exenatide. Basically, it was discovered because one of the fish which was found in the Americas could eat almost half of its body weight without increase in the blood glucose levels, and that is when we had one of the molecules which was found in these fishes, and analogs of this was developed, which was exenatide. Basically, it has an incretin effect. The incretin effect is whenever you have orally administered glucose, it exerts a greater insulin response than parenterally administered glucose, particularly because the incretin hormones, which include GIP and the GLP-1. GIP is secreted by K cells, GLP-1 is secreted from the L cells, predominantly located in the distal small intestine and the proximal colon. So the native GLP-1 is very labile and gets disintegrated by the DPP4 enzyme, but the GLP-1 receptor agonists are resistant to DPP4 degradation and have a prolonged response. So the therapeutic agents are administered subcutaneously except for semaglutide, which can be orally administered also, because semaglutide and other GLP-1 receptor agonists at the 8th position, there's slight variation in this molecule which has circumvented this obstacle, and that is why you can actually go on to give semaglutide as an oral formulation for diabetes as well as weight management. The primary pathway of action is basically the adenylate cyclase pathway, cyclic AMP level increment, and the protein kinase A pathway, which results in increase in the intracellular calcium levels, and the alternate pathway is basically the PI3K in the EKT pathway. As we can see in this slide, the primary mechanism of action, GLP-1 analogs act at the GLP-1 receptor, increasing the cyclic AMP and increasing the intracellular calcium, which is the major mechanism of action. The alternate pathway also works by the PI3K and the EKT pathway. Now this acts at multiple levels, not only on the pancreas, but also on the adipose tissue, the muscle, the liver, the intestine, the stomach, the cardiovascular tissue, as well as the brain. So we can see here that because of the central action, there is reduction in the appetite, there is delayed gastric emptying resulting in early satiety, there is improvement in the renal function, increased insulin secretion and decreased glucagon secretion by the pancreas, decreased beta cell apoptosis, as well as action on the muscle resulting in increased insulin sensitivity, and also cardioprotective effects in the form of increased cardiac output and anti-inflammatory action in the coronary arteries. So we have reduced rates of stroke, CAD, improved pancreatic function, improved glucose, decreased weight, decrease in the hypertension, improvement in the renal function, decrease in the rates of peripheral vascular disease. All of these are polymorphic or pleiotropic effects of GLP-1 receptor agonists. The basic mechanism is promotes the insulin secretion, decreases the glucagon secretion from the islet beta and the alpha cells. It limits the postprandial glucose by decelerating the gastric emptying, resulting in slow glucose intestinal absorption, resulting in reduction in the postprandial glucose level. The GLP-1 receptors are not only on the pancreatic islets but also in the cardiomyocytes, endothelial cells. Basically on the cardiomyocytes, they are going to reduce the oxidative stress, they are going to reduce the apoptosis of the cardiomyocytes. It also results in increased levels of nitric oxide, which is a vasodilator, and it reduces the endothelial stress. They also modulate the renin-angiotensin-aldosterone system, acting at multiple points in the RAS pathway, reducing the vascular tone, reducing the peripheral vascular resistance, and reducing the blood pressure. So the vasodilatory effects reduce the SVR and also reduce the blood pressure. So GLP-1 receptor agonists, they act at multiple pathways. They decrease the renin activity, reduce the secretion of renin, and because of decreased renin, we have decreased aldosterone and angiotensin levels, and we also have promotion of natriuresis, right? By the juxtaglomerular cells, in the juxtaglomerular cells, it reduces the renin, and hence it also reduces the angiotensin 2 levels, and because of the low angiotensin 2 levels, it also reduces the aldosterone secretion and causes natriuresis. So the clinical outcomes are reduction in the BP, less of vasoconstriction, reduction of the sodium retention, and reduction of the volume overload, reduction of the blood pressure, and hence we have a major benefit in terms of CV and renal protection, because it basically acts as a complete blocker of the RAS pathway, starting from reduction of renin and angiotensin to reduction of aldosterone and reducing the oxidative stress and the inflammation. So they are going to have natriuresis, promotion of the salt excretion, reduction of the BP, reduction of systemic vascular resistance, also reduction of the inflammation and oxidative stress, and that is why you are going to have multiple effects on the cardiovascular tissue. So in the myocardium also, it works by pretty much the same mechanism. GLP-1 receptors are present in the cardiomyocytes as well as the coronary arteries. Because of the action and then increased nitric oxide production, it causes vasodilatation, and by increasing the cyclic AMP levels in the cardiomyocytes, it reduces the oxidative stress. Right, systemically, it works on the pancreas, it works on the liver, it works on the adipose tissue, it works on the muscle, and exerts its multiple beneficial effects. So GLP-1 receptor agonists can prevent the endothelial dysfunction through the promotion of angiogenesis and reduction of the oxidative stress. The proangiogenic effects are mainly driven by the regenerative progenitor cells, consisting mainly of the hematopoietic progenitor cells and the endothelial precursor cells, and the antioxidative actions of GLP-1 receptor agonists. We also have suppression of hyperglycemia and dyslipidemia, which are associated with reactive oxygen species production. Together, improved angiogenesis, reduced oxidative stress, reduced inflammation will actually go on to improve the survival of the endothelial cells, and that is when we are going to have reduction of the arterial stiffness, reduction of the SVR, vasodilatation, improved blood flow, and improvement in the microvascular perfusion. Again, this is the chart which shows the same thing, that GLP-1 receptor agonists actually improve the angiogenesis, acting at the HPC as well as the APCs, and also reduces the oxidative stress, and therefore it improves the endothelial function and reduction of the oxidative stress and the inflammation. So again, pleiotropic effects of GLP-1 receptor agonists acting at multiple pathways: the progenitor cells, the cardiomyocytes, the foam cells, the fatty plaque, the macrophages, working on the fibrous cap, and also working on the MMP pathway, and having a lot of vasodilatory and anti-inflammatory effects, and results in stabilization of the coronary plaque and reduction in the rates of cardiovascular events. So how this exactly goes, maybe it works differently on the different cells and also has multiple mechanisms of action. So basically it has some the effects can include the suppression of the inflammatory cytokine production, the suppression of monocyte recruitment and infiltration, suppression of intimal thickening, and suppression of the pro-inflammatory macrophages as well as the foam cells. So coming to the different kinds of GLP receptor agonists, we here have a lot of names and can become very confusing, but these are mostly in the order in which they have been identified. Exenatide, as I said, was the first subcutaneously approved drug. I think very infrequently used these days, approved initially in 2005. The next was lixisenatide. The next drug which came was liraglutide, comes by the name of Victoza, subcutaneously administered 0.6, 1.2 or 1.8 milligram once daily, right? So Victoza is once daily, 0.6 to 1.8 milligram. Then we have had the very important drug semaglutide, can be given subcut or orally. If you are giving it subcut, you give it once a week at 0.51 or 2 milligrams. If you are giving it orally, you give either 7 milligram or 14 milligram once a day, right? So semaglutide comes by the name of Ozempic. If you are giving it subcutaneously, it comes by the name of Rybelsus or Wegovy if you are giving it in the oral formulation. Then we have different drugs. We have albiglutide, dulaglutide, several GLP-1 receptor agonists, but I think from this chart the two most important drugs which we can see is liraglutide 0.6 to 1.8 milligram subcut once daily, semaglutide 0.5, 1 or 2 milligram once a week, or 7 or 14 milligram of oral semaglutide. Now we have a lot of data. This chart can again become very confusing, but I would say that the most important drugs over here is the first trial, the leader trial, 9,000 patients of liraglutide, subcutaneously administered 1.8 milligram per day, significantly reduces the risk of MACE against placebo. Then the third, the Sustain-6 trial, 3,200 patients, semaglutide subcutaneous, administered once a week, 0.5 or 1 milligram, also reduces the rates of MACE, right? And then we have the Pioneer-6 trial, the second last column, orally administered 14 milligram per day. We did not show any significant reduction in the MACE compared to placebo, but again this became a very popular drug for the management of weight loss. So these the leader trial, the Sustain-6 trial, the Pioneer-6 trial are very important. Leader trial for the liraglutide, the Sustain-6 trial for the semaglutide, and the Pioneer-6 trial for orally administered semaglutide. Again, these landmark trials, we've had the semaglutide select trial, reduces the MACE by 20% versus placebo, reduces HbA1c 0.3% versus placebo, and weight reduction of 8.5% versus placebo. Then again, we've had the Pioneer-6 trial, semaglutide 14 milligram orally reduces the 3-point MACE by 21% versus placebo, HbA1c by 0.7% versus placebo, and weight loss of 3 kg versus placebo. Then we've had trials of dulaglutide as well as albiglutide. Then another very important one was the Sustain-6 trial, reduction in the MACE with semaglutide 0.5 milligram versus 1 milligram versus placebo. Semaglutide 0.5 reduces HbA1c 0.7%, 1 milligram reduces by 1%, reduces weight by 2.9 and 4.3 kg versus placebo respectively. And then we had the leader trial which also showed reduction in the 3-point MACE as well as reduction in HbA1c and weight loss of around 2.3 kg. So the leader trial, the Sustain-6 trial, the Pioneer trial are very pivotal trials in the management of diabetes as well as weight loss in the GLP-1 RA era. Right, the FIGHT trial for GLP-1 receptor agonist and heart failure, no benefit in liraglutide versus placebo. The LIVE trial, influence of liraglutide in patients with chronic heart failure, they did not benefit from therapy and also had a high risk of developing arrhythmias. Semaglutide 2.4 milligram once daily in patients with obesity related heart failure and preserved EF. Semaglutide led to weight loss, heart failure improvement symptoms, and significant difference in the 6-minute walk test, and it showed that semaglutide is beneficial in non-diabetic patients with HFpEF as well as obesity. Heart failure has not been studied as one of the pivotal endpoints. in most of these trials. NYHF4 was an exclusion criteria in the leader, SUSTAIN-6 as well as the ELIXIR trial. Failed to show benefit in reduction in the risk of heart failure in the leader, REWIND, ELIXIR and SUSTAIN-6 trial. No significant difference in heart failure hospitalization between GLP-1 receptor agonist and placebo group. So I would say that this is not a very important drug for the management of heart failure. That is why it has never been incorporated in the guidelines, and still we have only 4 pillars. GLP-1 does not form a part of the pillar of the heart failure management, but for ASCVD patients, reduction of ASCVD and diabetes and weight loss, it certainly is a very important molecule. The potential in heart failure is really there, but we need dedicated studies with large sample size because of its effects on RAS as well as vasodilatation and direct action on the myocardium. So comparing GLP-1 with GLP-1 receptor agonist with SGLT2 inhibitor, we know that they act by complementary pathways. The SGLT2 inhibitor is going to cause natriuresis, it's going to cause glucosuria, it's going to reduce your glucose levels, it's going to improve the peripheral sensitivity, it also has a direct myocardial side effect, it's going to reduce your uric acid levels, also going to reduce the inflammation as well as the proteinuria, right? So multiple mechanisms of action of SGLT2 as well as GLP-1 receptor agonist, both of them are going to act through similar mechanisms of action and maybe a synergistic mechanism of action, going to reduce the urinary microalbumin excretion as well as reducing the activation of the RAS, right? So SGLT2 basically, because it's going to increase the urinary glucose secretion, it's going to reduce your glucose levels, and that's why it reduces the insulin, increases the glucagon levels, right? Whereas GLP-1 receptor agonist will cause more of appetite, it delays the gastric emptying, it improves the insulin secretion and reduces the glucagon levels, and that is why they counteract each other in this point, and the adverse effects of SGLT2 in terms of decreased insulin are mitigated by the use of combination with GLP-1 receptor agonists. Common effects, so these were the contrasting effects that the levels on the basically insulin are different in the two groups of drugs. The common effects include reduction of the hyperglycemia, both promote weight loss, both reduce the albuminuria, both improve the renal functions, both reduce the MACE, heart failure, hospitalization, as well as the blood pressure. So basically GLP-1 receptor agonists improve the satiety and improve insulin, decrease glucagon. SGLT2 inhibitors increase the glucagon, decrease the insulin, decrease the renal glucose absorption, and also cause natriuresis and reduce the preload, afterload, as well as the cardiac fibrosis by its direct effect on the myocardium. So, the important trials, the leader of liraglutide, heart failure hospitalization not significantly different, cardiovascular death was lower in liraglutide versus basically the placebo group. Also we showed reduction of the nephropathy. Then we have the SUSTAIN-6 of semaglutide. Again, heart failure did not have any major difference, but MACEs were significantly reduced in diet. So leader was diabetic with ASCVD. SUSTAIN also was with diabetes with high severe risk or ASCVD. We showed reduction in MACE, no reduction in heart failure, improved renal outcomes in both. Then we had the EMPA-REG outcomes of empagliflozin, diabetes with ASCVD, showed reduction in the MACE as well as heart failure hospitalization and reduction in the nephropathy. Canagliflozin also showed similar findings. DAPA-HF for diabetic with heart failure showed reduction in cardiovascular death as well as heart failure hospitalization. And EMPEROR-Reduce also showed reduction in the heart failure hospitalization. So both classes are recommended by ADA and EASD as first-line therapy for patients with diabetes with ASCVD or multiple ASCVD risk factors. The ADA consistency report also recommends the combination of GLP-1 with SGLT2 whenever HbA1c target is not achieved with a single drug. Further recommend SGLT2 as first-line therapy in patients with diabetes with heart failure. SGLT2 is a first-line therapy in diabetes with chronic kidney disease, and in case of CKD, use of GLP-1 receptor agonist with proven cardiovascular benefit is only recommended in those who have not achieved the glycemic target despite SGLT2 inhibitors, right? So we've had a lot of single SGLT2 receptor agonists. The two most important molecules here I would say are liraglutide, and more commonly used nowadays is semaglutide. Then we have something very new, which is a dual mechanism of action, GLP-1 with GIP. So GLP-1 basically enhances the insulin secretion, reduces the glucagon, decreases the gastric emptying, and reduces the weight as well as appetite. We have seen that. So additionally, tirzepatide is a molecule which acts on both these pathways, acts on the GLP-1 pathway and the GIP pathway. By acting on the GIP pathway, it further causes insulin secretion, improves the insulin sensitivity, and reduces the lipotoxicity. So GIP may restore insulin secretion in beta cells which are actually desensitized, and when you combine both of these, you are going to have a really good HbA1c reduction with weight loss. So GLP-1 plus GIP acting on the pancreas and the glucose homeostasis via the GLP-1 pathway, as well as the stomach and the brain, and the GIP pathway mainly acts on the adipose tissue, skeletal muscles, and the insulin. So it's subcutaneously administered once a week, not available orally. It's subcutaneous route is preferred. Half-life is very long, 5 days. Metabolism, it's a proteolytic degradation, elimination renally. Side effects are mostly GI because they are going to cause nausea, diarrhea, constipation, some injection site reactions. And sometimes we've seen that when you have both of these, when you have a dual mechanism of action, there is slightly increased risk of medullary carcinoma of thyroid because of activation of GLP-1 receptors in the C cells, causing increased secretion of calcitonin and reduction of increased rates and resulting in increased rates of MTCs. Another landmark trial, the SURPASS-2 trial, once weekly tirzepatide versus semaglutide in diabetics. We've had a lot of patients, 1800 patients, randomized either to tirzepatide 5 to 15 milligrams subcut once a week versus 1 milligram of semaglutide. We saw that A1C reduction, we saw that the primary outcome basically was minus 2.3% with tirzepatide versus 8.6% with semaglutide, right? So tirzepatide is really going to change the management of patients with diabetes. Then we have had the SURPASS trials, basically comparing A1C reduction and weight reduction with tirzepatide versus placebo. The SURPASS-1, we showed that HbA1c reduction of almost 2%, weight loss of almost 7 to 10 kg. Against semaglutide, we see that A1c reduction is better, weight reduction is better. And the SURPASS-3 trial also, we see that weight reduction and HbA1c is much better. So it has been compared versus placebo, semaglutide, glargine, as well as several other agents, and we've seen that tirzepatide outscores all of these molecules. Placebo, the primary outcome was percentage change in the body weight with 15 milligram dose. We saw that versus placebo, there was a significant reduction in the body weight, 20.9% versus 3%. And the percentage of the patients with at least 5% body weight reduction was achieved in 91% in the tirzepatide group versus 35% in the placebo group. And adverse events causing treatment discontinuation were slightly higher, but conclusion was that in a 72-week trial, 5 milligram, 10 milligram, or 15 milligram of tirzepatide, which is marketed by the name of Mounjaro, once weekly subcutaneous provides substantial and sustained weight reduction. So now, obesity, metabolic syndrome, hyperuricemia, non-alcoholic steatohepatitis, or what is commonly now known as metabolic disorder, metabolic dysfunction associated with steatohepatitis, all of these are combined disorders, and you need drugs which act on multiple pathways rather than just sugar control. So if you are going to give them sulfonylureas and metformin, you're only going to actually reduce their blood sugar levels. They are not going to affect the cardiovascular function, heart failure, future ASCVD. So that is why you need molecules like SGLT2 inhibitors, GLP-1 receptor agonists, or a dual GLP-1, GIP-1 receptor agonists, which act on multiple pathways, including the coronary arteries, the endothelium, the pancreas, the brain, the liver, the kidneys, skeletal muscle, adipose tissue. And that is why these molecules, SGLT2 and GLP-1, really outscore other anti-diabetic agents, and there is a reason these molecules are now recommended as a class 1 indication for patients with diabetes. So if you look at the recent ADA guidelines, these molecules are now class 1, and then if not controlled with these, you add other molecules like TPP4, sulfonylureas, and metformin. So they are not just glucose lowering agents, they are cardio, kidney, metabolic molecules. So CKM is a very new terminology, cardio, kidney, and metabolic. It encompasses almost the entire system, the cardiac function, the renal function, the metabolics, including the lipid profile, the sugars, A1C, insulin sensitivity, the CRP levels, the inflammation, the oxidative stress. All of these is encompassed in the term CKM, or the cardio, kidney, metabolic, and GLP-1 and SGLT2 are really CKM molecules. They reduce the MACEs, including CV death, stroke MI, and they cause weight loss and offer renal protection. They're very valuable in patients with diabetes, and I would say that for diabetes per se, if you want to use one molecule, I think you should go for semaglutide, and for weight management, if you want to use one molecule, I think we should really go for tirzepatide, because it offers almost 15 to 20% reduction in body weight at 1 to 1.5 years follow-up. Thank you.